Hi viewers, Dan and Mitch here, and today we're going to give a small presentation on healthcare with an economic focus. This would be the perfect time to focus on COVID-19 and its ongoing effects on society, whether it be the burden on healthcare, the products related to healthcare, or even the effects of lack of nightlife that has arisen from the crisis. We will focus on home rather than abroad, but compare figures where it's supportive. When we discuss COVID-19 or the coronavirus, we'll cover some of the topics from the course notes and then explore the current and potentially lingering economic consequences for such an impactful time. Resources will be shown at the end of the presentation.
What do we expect in healthcare? Well, in this country, do we deem healthcare as a public good? It is necessary for our survival, but also comes at a premium. We have both public and private healthcare systems, a Medicare which takes care of some basic costs, but is it exclusively a public good? Although the public health system in terms of service, quality, and affordability is one of the highest ranked globally, it is not without fault in keeping up with our needs and current climate. The healthcare system must devote a lot of time and resources for an aging population, which require more federally provided care than younger users.
As technology advances, more effort, time and resources must be pulled into healthcare to keep it at the high standard that it currently is. It is imperative as a product to maintain or increase quality rather than decline. This would be much worse in the stakeholders' or users' eyes than a perpetual rise in costs or government funding. We see the negative effects near weekly when a local news article does a piece on conditions of nurses or the funding cuts that may not provide enough hospital beds. Studies and statistics have shown that infant mortality rates have declined and life expectancy has increased almost to the century milestone. The needs of an aging population creates a larger demand on the public health system. We can see the rising costs and more importantly the proportions when comparing the private and public health sector. The increase in demand is unfortunately a burden on a decreasing pool of taxed and contributing workers. Does this imply a free rider problem?
The free rider problem, in a nutshell, is when users are taking advantage of a good without contributing at another user's expense. Some believe this is the case. I don't think that it fits the criteria for the free rider problem. With any public good, globally, there is always a negative portion of demographic that abuses the system and will be a free rider at every opportunity. But healthcare for an aging population doesn't fit the criteria. If at a specific point of time you can say the elderly in care aren't currently contributing, but from time we legally work as users, we are paying taxes, which increase funding to medical research, care and other related expenses. This is an insurance in its own regard. When looking at minor demographics with negative factors such as welfare cheats and other non-contributing users, we can look further into the free rider problem if it's prevalent. Although, these groups are gaining the benefit at other users' expense. Whether it tracks from tax-paying users is up for discussion. A relevant factor is whether scarcity is taken into consideration. If and when medical resources, time and availability are in abundance, then there is no free rider problem, as the public good is not hindered or depriving the tax-paying user. However, when scarcity is prevalent, which is currently a very relevant factor, then it can be said to have a minor free rider problem.
From the previous topic, it is clear that scarcity is a problem globally in healthcare systems. As populations grow, new technologies have developed, healthcare professionals have more access to information. With the sharing of information, the resultant is that diagnosis has globally become better. Although this is great for the first-hand user, as more ailments are diagnosed, it increases demand on resources and in turn, without proportionate funding, makes scarcity more and more prevalent and obvious. For the current times, this was extremely obvious with the COVID-19 pandemic. As users, the first thing that we've seen to disappear from market shelves were hygiene products. Even hardware stores, chemical suppliers, and supermarkets were out of raw materials that are needed to make sanitizers and face masks. As a result, in visits to medical centers and hospitals, users were stealing medical products out of fear and, in some cases, dire necessity, which further increases scarcity on a smaller scale. The outbreak was almost immediate, and things are just starting to begin the long road to normalization. Another form of scarcity exists in the doctor-patient relationship. Human resources are stretched thin, and it is the skilled workforce that has always been in a state of being understaffed, from orderlies to nurses and doctors. With the current global pandemic, scarcity has seen many forms and has brought issues and problem areas, the allocation of resources and the economic state of the healthcare system, into public view.
With the COVID-19 outbreak, we've had a number of immediate society changes. According to the Australian Bureau of Statistics, the impact of the bushfires had seen unemployment at the start of March at 7.2%. By then, at the end of March, 12.2%, and unemployment at 9.4%. Some of the hardest sectors hit was hospitality, with over a third of the employers and employees unemployed due to restrictions, which include travel and isolation. This followed by the arts at just under 30%. The government has provided stimulus and readily available welfare, but this has created an increase to national debt and a further strain on diminishing a pool of taxable users. Due to a global panic, the healthcare system has seen a spike of patients, whether infected or not to be tested. A snowball effect then streamed down to materials and personnel available for testing, and screening procedures were then put in place to limit the conditions of testing, to allocate resources in a more efficient and frugal manner. So, with an increased need of funding from an increasingly smaller pool of resources, scarcity has never been more prevalent in modern times for the Australian healthcare system.
Due to isolation and quarantine procedures, the close of bars, restaurants and clubs has had an interesting effect on the healthcare system. The balance really needs a retrospect, so from numerous news sources we'll summarise the current findings. Now that alcohol is not as readily available in a non-social setting, there is less alcohol consumed on average and can be seen when comparing data on the volume of alcohol sold. Although there has been a spike in liquor shop sales, less has been consumed on average due to the isolation. Without access to gambling, such as poker machines, the amount of revenue from gambling generated has drastically decreased. The balance that needs to be analysed in retrospect is that there is less alcohol-related violence, health problems and social narcotics being taken. Although the tax revenue generated from sales has decreased, so has the burden and demand from resources from the healthcare system. The figures in retrospect will be very interesting indeed.
As sectors start to get a reopen, particularly with hospitality, and life gradually starts to return to normal, we will see a change in demographic. As a result of isolation and the restriction for being in public are limited to necessary shopping, work and exercise, there has been observed to be a larger group of people exercising as a result. People are eating better for the most part, as with the employment situation, as money has tightened with the uncertainty of the situation. Users are more frugal with their spending. If the trends continue, then there theoretically be a lessened burden on the healthcare system due to leading a healthier lifestyle out of the necessities. From one of the latest reports, we can see health benefits to the isolation procedures that have been implemented. As users are more conscious of social distancing, sanitation procedures and personal hygiene, hospitals are reporting a dramatic decrease in influenza and other bacterial illnesses. So what does this mean within the public good? There is a noticeable change in allocation of resources. Less minor cases are being contracted and there is less strain for care workers. The resources have been able to be shifted and reallocated accordingly, which puts less strain which puts less strain on the monetary and human resources.
In retrospect, there have been several things that the healthcare system has learnt. The stopping of elective surgeries has seen the private sector reducing the workforce instead of reallocating and integrating the needed skilled staff to the public sector. In the public sector, GPs are criticised for using an outdated funding system and relying too much on Medicare and not complying to the needs of society. The current online help is being scrutinised as it is being exploited and overburdened by corporate groups and leaves little to no time available for the common user.
According to Scott and Braithwaite, an economic analysis, a cure for this condition is to have more resilient funding approach. What is suggested is a capitation payment. This is when publicly funded resources are supported by a fixed payment from the user per year. This will supplement already available public services and ensure a level of care and service that is to the quality that we receive now. The aim is to free resources that are being abused and exploited. The practice is being implemented in the healthcare homes for people with chronic illnesses. Scott and Braithwaite suggest in publicly implementing the payment scheme, it is also suggested that the divide between public and private health systems is too fragmented, and in order to get better cooperation, allocation of resources, and even level of funding, that homogeneizing the organisation to a degree will be beneficial for user care. Their journal article has been met with mixed reviews, and some comparing England's NHS. The consensus of replies is that while benefiting some users, overall it is not possible for others to pay their capitation payment. It is almost trying to address the free rider problem while trying to generate more funding for the healthcare system to adapt a semi-private model. However, without more data, this may or may not be a valid course of action post-COVID-19.
In researching this broad topic, it has been interesting to see how social and global instances have affected the healthcare system on an economic level. We can see the effects of scarcity and uncertainty during the pandemic, and how this uncertainty has changed resources and their allocation, surprising positives but unmonitored effects, and how the cracks in the current system has left the need of a solution, but without a certain and homogeneous fix that is yet to be seen at this time. Thanks and have a good day.